Hi, everybody. I'm Paul Beatty from Wilderness Physical Therapy Educators, and welcome to our next lecture. In this presentation, we're going to be talking about respiratory problems in the backcountry. And what we're going to do is a little something different in this presentation, in that we're going to follow a video of a patient encounter in the backcountry. And what we'll do is we'll start with a video that discusses the person's chief complaint. Then we'll go back to some slides for a while. We'll come back to the video that demonstrates the exam. We'll go back, we'll talk about some more conditions, and then we'll finish up with a portion of the video that discusses the treatment for this individual. So we're real excited, as always, that you guys are here and looking forward to this presentation. And let's go ahead and get started. Thanks again. Hi, everyone, and welcome to another edition of Wilderness Physical Therapy Educators. In today's scenario, we have been out hiking. It's a beautiful afternoon. And at the end of our hike, we're walking into our campsite and we notice that there is a person who's sitting on a log by the campfire with his pack off his back. And it looks like he's in a little bit of discomfort. So in our scenario, we're going to walk up to him. We will introduce ourselves. We'll ask his permission, and then we will go through a primary and a secondary exam and see if there's something we can do to help him out. Hey, how's it going? Hey, how are you? My name is Paul. I'm trained. Do you need some help? Can I help you out a little bit?
I guess, yeah.
Oh, great. Let me sit down for a minute. How you doing? How's things going out on the trail today?
Good day.
That sounds really good. What's bugging you? You doing all right?
I just feel like I can't catch my breath.
Okay. How long's that been going on?
I don't know, we hit 10 grand back there a little bit. I just felt like after that, I just can't breathe real good.
The objectives for this presentation are to recall the key questions to ask a person who has respiratory problems in the backcountry. And secondly, importantly, to be able to discuss the first response treatment options for acute respiratory problems. When we think about respiratory problems in the backcountry, it's important to consider several of the risk factors that can occur. One of the big ones that we've talked about in previous presentations, of course, is altitude and the effect of a hypoxic environment on people who have pre-existing respiratory conditions. Also, exertion can be a big issue in people who are working out in the backcountry and may not be used to that. And finally, air quality is a big concern, especially in people who have asthma. Things like wood smoke, dust in the air, and all these things can be triggers to cause somebody to go into respiratory distress. Another big issue is when we have people who have COPD who are doing okay and they may go up into altitude, they may decompensate and start to develop signs of respiratory failure.
Yeah.
Is it all right if I take your pulse right now?
Yeah.
Great. Let me just ask you a couple questions. What's your name?
Darren.
Darren? Do you know where you are right now, Darren?
Yeah, we're in Tetons.
Do you know what day it is today?
Yeah, it's Monday.
Okay. You've already told me what's going on. It sounds like your pulse isn't too bad. That's good. I'm asking you a little bit of questions about your medical history. Is that okay with you?
Yeah.
Great. So are you having any problems besides the breathing?
No.
You having any pain in your chest at all?
No.
You've been sweating a lot, losing a lot of fluid?
I mean, it's been a little warm today, but no more than normal.
Okay, not having any trouble, any pain anywhere, moving your legs, any of that kind of stuff?
No.
Do you have any allergies?
No.
Okay. Are you taking any medications right now?
No.
Okay. Tell me a little bit more about how this all came about.
Like I said, we're hiking. You know, I'm from the East Coast. We were hiking today, and my guys are just over there, but we hit 10 grand, and I felt pretty good about that. And then after that, just feel like I can't quite catch my breath. Like it's there, I just can't quite catch it.
Okay. Have you been drinking more water today and other stuff?
Yeah.
Tell me a little bit about what you've been drinking.
Just doing some water, and then I got the Gatorade mix that I'm doing every once in a while when we stop.
Okay. Have you ever had any trouble coming up to high elevation before?
No, I mean, I've done a couple 14ers. Yeah, it's kind of weird. Yeah.
Okay. What we're going to do now is we're going to go ahead and just do a quick exam and see if there's anything going on here. Okay?
Okay.
Great, thanks. And at this time, we would then go ahead and listen to Darren's lungs and do a little bit more of an examination. Our big concern right here is going to be what? So you guys take a minute now and everybody write down what you think would be the big life threats, what you think would be secondary problems, and how we would go for there. And then we'll pick up in a couple of minutes and we'll go through those. The key components that you may find when you take your sample history are as follows. During the S portion of the sample history, the symptoms, many, many things we want to ask our patient about or that we may observe, such as dyspnea, wheezing, pain with breathing, the potential to have fever, productive cough, or dizziness. The A in the sample history could indicate people who have a history of respiratory response to antigens, especially people with asthma. The M would be in a person who may be using an inhaler. And the past medical history is very important for people who may have had pre-existing conditions such as asthma, pneumonia, or COPD. The L in our sample history is very important for people with respiratory problems to determine if they're having adequate nutrition and adequate hydration. And finally, the E would be, again, to look at the onset and the duration of symptoms. Is this person's problem getting better? Is it getting worse? On physical exam, we want to observe for any signs of inadequate respiration, such as cyanosis. We're also looking for the work of breathing that might be represented by somebody who's really puffing hard or tripoding. And we're also looking for the amount and the symmetry of chest expansion during respiration. It's important to count the number of breaths, and hopefully our patient will be breathing somewhere greater than 8 and less than 28 breaths per minute. We're going to listen for the presence of wheezes and stridor. If you happen to have a stethoscope, that's a really good time to use it and to look for the presence of vesicular lung sounds and normal breath sounds. If you don't have a stethoscope, people have talked about taking a Nalgene and putting that up against the person, empty Nalgene, and putting that up to be able to amplify some of the breath sounds. We also want to palpate the person's chest while that individual is breathing, so we can get a manual sense as to the amount of chest expansion. We're palpating to determine if there's fremitus, which could be a change in the way that sounds go. If you ask the person to say E, it may come out as ah when you listen to the chest or feel for the chest. We're feeling for pleural rubs that might have a friction type of feel to them. And then finally, we might want to percuss along the chest wall if we think there might be some areas where there's fluid in the lungs, and tap on the ribs to look for the presence of resonance that may indicate some different types of problems. The red flags that we're looking for that are cardinal signs of respiratory failure, key to this would be shortness of breath or air hunger. And this could be manifest by the patient's inability to speak in full sentences, where they might have 1 or 2 word dyspnea, where they can't complete a sentence but can only utter a few words before they need to breathe again. We're also looking for the presence of tachypnea, or the person breathing too fast. We're looking for fatigue, or listening for and asking the patient about fatigue. We're palpating for fast heart rate or the presence of palpitations. We're observing to see if the person's coughing up blood or has hemoptysis. We're also observing and palpating to see if the patient is sweating excessively or is diaphoretic. We're also looking for the presence of agitation or altered mental status. And in a person who has idiopathic chest pain, we're looking to see if they may have unilateral leg swelling that might indicate a DVT that has mobilized and resulted in a pulmonary embolus. Now, there are many common causes of dyspnea that we may encounter in the backcountry, and we've already discussed quite a few of these. And for example, we've talked about rib fractures, we've talked about pneumothorax and cardiac problems. We've also talked about pulmonary embolus, and in previous lectures, we've discussed high altitude pulmonary edema, or HAPE. Some new causes that we'll talk about in this presentation include asthma, COPD, hyperventilation, choking, and finally, carbon monoxide poisoning. Let's start with asthma. When you see a person who has asthma who is starting to have trouble, one of the cardinal signs will be coughing and wheezing. You may also encounter labored breathing, and as we just mentioned, this person may have shortness of breath associated with 1 to 2 word dyspnea. The patient may complain of tightness in the chest, and because this person is experiencing air hunger, we may have a lot of fear and potentially even confusion. And finally, this person could be sweating profusely. The treatment for an acute asthma attack is number one, to reassure the patient, to get this person to stay calm, to relax, which is hard to do. And if somebody's having air hunger, we try to position the person in a position of comfort and perhaps start with some synchronized breathing just to get them to slow things down. Now, hopefully the person will have an inhaler and we can assist them with the inhaler. And the steps that we take to do this would be to ensure that the prescription is correct, number one. Number two, to shake the inhaler and to remove the mouthpiece. We ask the patient to breathe out all the way, then put the inhaler in their mouth, take a good deep breath and hold it for about 10 seconds. And then we might need to repeat this in 1 to 2 minutes and make the patient comfortable. A second series of disorders that we may see in the backcountry, as we mentioned before, could be uncompensated COPD. And as you guys all remember, COPD is a term that describes a variety of conditions, including emphysema, chronic bronchitis, and severe long-term asthma. And COPD is characterized by histologic changes in the parenchyma of the lung that make it hard for the person to expel air. And there's various degrees of severity for COPD, ranging from mild to very severe. And these are measured by the forced expiratory volume in 1 second. And again, you'll remember this from your training. The normal amount of air that can be expelled in 1 second for females is somewhere between 2.5 and 3.2 liters. For males, it's somewhere between 3.2 and 4.5 liters. And importantly, a person should be able to expel about 70% of their forced vital capacity within about 1 second. And so we look at the 0.7 value or 70% value as being what we're looking for, and people who are not able to expel that much will then start to reach the point where they can be classified as having various degrees of COPD. The risk factors for COPD, it's a little bit more common in females, and it's much more common in people with a history of asthma and chronic bronchitis. Much more noticeable in older patients, which is important because when you see older folks on the trail who are having trouble breathing, quite often they can have a history of COPD. As we all know, current and former smokers are at elevated risk for this. And interestingly, one of the things that's been determined to cause COPD also is exposure to indoor and outdoor air pollution. And in today's society, in many, many places, indoor air pollution is more substantial than is outdoor air pollution. And indoor air pollution often caused by things such as air fresheners and laundry detergent, dryer sheets, things like that, that have very, very strong scents that can result in chronic inflammation of airways. Now, people who have COPD often have concomitant heart problems such as cor pulmonale, and they may be at elevated risk for arrhythmias, for congestive heart failure, and for myocardial infarction. There's some interesting things about COPD, and when we inquire and see folks in the backcountry that have this condition, many people can decompensate as they get to higher elevations due to hypoxia, as we mentioned before. And this person may be doing well at sea level, and then they come up to the mountains for a vacation or for a hike or something, and then they can start to get into big trouble. And this is especially true if they start to have areas of airflow restriction, which in turn can cause them to retain too much CO2 and get hypercapnia, and also to have too little oxygen in the blood or hypoxemia. Now, the symptoms for COPD included dyspnea, oftentimes a productive cough, and oftentimes wheezing. And people will typically have reduced exercise capacity and will start to get out of breath, doing much less than you would expect. Also, individuals with COPD have a lower threshold for respiratory infections, and so they're at great risk to develop colds and flu and pneumonia. They're also, interestingly and importantly, at elevated risk for acute mountain sickness and for high altitude pulmonary edema. The treatment for decompensated COPD, and this is important because it's a little counterintuitive. You want to stay calm and try to reduce the person's oxygen demand, which of course makes sense. Again, get the person to breathe with you and to try to reduce their need to bring in oxygen and to expel air. So we can do different types of breathing exercises, diaphragmatic breathing, and synchronized breathing, stuff like that. Now, you would think that if a person were starting to have difficulty with COPD, that they would need high flow oxygen. And this for many, many, many years was the case in EMS care and emergency room care. But it's been shown that if you elevate too many, a person with COPD, if you elevate them too quickly with inhaled supplemental oxygen, that this can increase their PaCO2, causing hypercapnia, and of course can lead to respiratory acidosis. So in this group, our target O2 sat is going to be somewhere around 88 to 92% at sea level, and this is versus about 95 or greater for people who don't have COPD, also at sea level. So we need to be a little bit cautious. Sometimes people will carry these little oxygen in a can things that you can purchase at the camping store and supplement oxygen. That's probably not a great idea for a person with decompensated COPD, unless you have a careful monitoring with a pulse ox. And again, being really careful to not over-oxygenate these folks. Quite often, once they can calm down and get out of acute respiratory distress, they should be able to walk out slowly. Now, choking is important. I thought I would throw that one in here because that can be a major, major problem of acute respiratory problems. And you all are familiar with the treatment for choking with your CPR, AED, BLS certifications that you get on a yearly basis. But again, it's important to just take 1 second, I think, for all of us to go back and to review this. So if a person is choking or you perceive them to be choking, the first thing is if the individual is making any noise, if they come in and they go, I'm choking, then don't do anything. Encourage that person to cough, and hopefully they'll be able to cough that out. If, however, the person is not making noise and is showing the international sign for choking with the hands around the neck, go up, introduce yourself, ask for permission to treat them. And if they grant that permission by nodding their head, then the guidelines today recommend starting with back blows, where you have the patient lean forward a little bit and then give them some good thumps in the interscapular area, followed by 5 abdominal thrusts, standing behind the person and pulling in and up at the level of the umbilicus. It's important to note that if there are any foreign bodies present, if you can grab it and pull it out safely, you can do that, but don't put your hands where you can't see. Because the one thing you don't want to do in a person who's choking is inadvertently push whatever that foreign object is down further where it could lodge into their airway. Finally, we'll talk about carbon monoxide poisoning. And this is somewhat common in the backcountry. We've talked about this, I think, in previous case studies. But where you see this a lot are in people who are using camp stoves in poorly ventilated areas. Could be raining and the person starts using their camp stove under their tent fly, which is a super bad idea. Or maybe using it in a poorly ventilated cabin or something like that. And what will happen is that person will start to breathe in the carbon monoxide. And the symptoms include headache, dizziness with further exposure can lead to shortness of breath, upset stomach, and vomiting. And finally, chest pain and altered mental status. at which point, obviously, this becomes a very, very serious problem. Complications to carbon monoxide poisoning include damage to the brain and to the heart. And it's a greater risk for older people, for infants, and for people who are pregnant. So the treatment for this, of course, is to always remove that person from the source, and hopefully they start to breathe regular clean air, which will help to restore their mental status and get their PO2 back up. Anyone who has been subjected to carbon monoxide poisoning should receive a front country evaluation to make sure that they're doing okay. And then finally, if EMS comes out, they will provide some supplemental oxygen, again, and assist in transport of this person to a front country environment. Hyperventilation, and we've all been familiar with this, it's really interesting, and this is rapid or deep breathing that's often caused by anxiety or by panic. And what happens is a person breathes in and out really quickly, blows off a lot of CO2, and starts to become hypocapnic. This in turn will cause a big problem with the pneumotaxic centers in the brain and influence their normal respiratory rate. People will become dizziness, will develop dizziness, will become lightheaded, and continue with shortness of breath. Oftentimes, people who are hyperventilating will develop bloating and a dry mouth, and in some cases, numbness and tingling in the extremities and around the mouth. So the treatment for this, for many years, we always talked about people breathing into a paper bag to try to increase the CO2 in their inspired air. This is actually not recommended anymore. Instead, it's recommended that the person do synchronized breathing with the provider. So slow breaths in and out using pursed lips to prevent from blowing out air too quickly. Hi, everybody, we're back. So we've had a chance to look at the differential diagnosis, and we've gone down our list of different possibilities for our patient having some respiratory distress here at our beautiful location. So what we've decided as we've gone through and looked at the different options is that he's at the end of a hard day's hike. We're just below the tree line up here in this alpine forest, and he's probably having a little bit of hyperventilation. So a safe and good thing to start with is just to do some synchronous breathing with our patient to see if he can start to feel a little bit better and enjoy this beautiful, beautiful place. So Darren,
Yeah.
I think a lot of the problem you might be having is maybe you just got a little hyperventilated on that last kick up there and that coming out of the canyon and getting up here. So a good thing is, why don't we try to breathe together and see if we can get you feeling a little bit better, okay? So we're going to breathe on my count. Ready? In and out. Here we go. 1, in, out. 2, in, out. And take your pulse again. 3, in, out. One more time. 4, in, and out. How are you feeling now? Start feeling a little better?
Yeah.
Great.
Better.
This might be a good time to enjoy some of that beautiful mountain spring water
Okay.
before it becomes time to start taking bear precautions and getting gear set up.
Okay.
Cool. You look good, buddy.
Thank you.
Great. Thank you guys again for joining us. We really appreciate it here at Wilderness Physical Therapy Educators. Now let's take a minute just to enjoy this beautiful campsite, and it'll be happy for all of us to be here and to get our tent set up and to get the campfire going. Well, I hope you guys enjoyed this lecture. As always, it's a real pleasure for us to be with you. And we look forward to seeing you down the trail. So thanks again so much for coming in, and we'll see you soon.